Welcome to another episode of How Did It Make Sense? The podcast where we look at that local rationality. How did it make sense? We look at two different versions of the same story. We talk about these first stories, which are simple, linear, often got judgmental, counterfactual language. And then we move into the second story, which is where the real learning happens, where we find out about the conflicts, the tensions, the workarounds, the adaptations. This part of normal work. And we do this across multiple different spaces. And today I've got Eoin Walker from the World Extreme Medicine Forum. It's how I know him. And talk about medicine. And I don't think we've had anybody in the healthcare space before. So Eoin, welcome to this session this morning.
Thanks, Gareth. It's lovely to be here.
We start off with an introduction. So who are you? What do you do? How did you get to where you are in sort of time and space now? And where can people find you in the real world and in the digital space if they want to get hold of you?
Yeah, thanks, Gareth. So I started off my life training as a paramedic down in London, qualified, moved down in 2001, qualified in 2004. And that was a story which really kind of brought me along on a journey of self-exploration as much as exploring the profession itself. You know, seeing people in their moment of crisis and everything in between, but certainly what would be a pivotal point for people, and really drew me into a fascination for human factors, actually, because there was a massive human factors interplay in what I did. So was in London for almost 20 years, actually. So I became a critical care paramedic, a flight paramedic, a ground-based paramedic, but did lots of other roles from being a paramedic onwards. Started to get into expeditions as well in that time. So started to travel the world with World Extreme Medicine, teach in various locations in the world, but also run expeditions as a medic and be there, which again had its own human factors component. And then stepped away from full-time practice, still retain and did some part-time clinical practice in 2020, but stepped away to work for the Red Cross in Cairo for a year, and then Nairobi/Somalia for half a year. Then came back to the UK to be a senior product manager for Philips, then Vancouver as the head of education for British Columbia Emergency Health Service, and then I'm now out in Germany working for Airbus Helicopters as the senior marketer for the Helicopter Emergency Medical Services.
Excellent. So where can people find you sort of digitally? LinkedIn and emails or websites?
Yeah, indeed. So LinkedIn, absolutely. I've got a funny spelling name. It's Eoin Walker, so it's Owen, but the Irish version. I'm the digital lead for WEM, so you can find me through WEM, World Extreme Medicine. I run 3 podcasts. So I run the Restore with Eoin Walker, which is a mental health, non-clinical podcast. I run the Purposeful Care podcast, which is very much a clinical, technical podcast for paramedics, doctors, and nurses. And then I run the World Extreme Medicine digital lead for World Extreme Medicine podcast. And so I'm in those 3 spaces, very much in the podcasting world myself.
Awesome.
But yeah.
Excellent. I'm really impressed. It takes a fair amount of time to put these things together. So awesome. I'm really interested in the sort of diverse background that you've got, and I'm sure you've got plenty of stories. So what's the first story of this event that you've got that you want to talk about today?
Sure. So we landed on scene. We got to a patient where we can't intubate, can't ventilate. We managed to secure this patient's airway with a surgical airway. Very challenging. And was a protracted event. We eventually managed to get her to a specialist centre, but extremely challenging.
Okay, no, that's cool. I mean, and I think, people just look at this and go, well, you're the professionals. How hard can it be to do this stuff? So what's the context? What makes it hard to do that activity and the messiness of dealing with a HEMS situation? Because, it wouldn't be urgent. It wouldn't be important if you didn't have to call the HEMS out. You're only going to be called out if it's a critical situation. And those critical situations are never simple or linear in their approach. So can you sort of tell us the second story, the more context-rich story, all of those factors that makes this really hard and brings that story to life to people to say, look, this is the reality being in a hem space.
Yeah, indeed. I think that the prevailing challenge is, as you alluded to, Gareth, that patients like this have a sense of finite time. So there's a time pressure against you, because if there's an airway problem, you don't have the luxury of just briefing the team in slow time, talking through the procedure, talking through the default procedure, really starting to mitigate primary or secondary complications. Everything is time precious and time rushed because the airway is such a priority. So we landed on scene. This patient had been on fire, running around on fire for over 5 minutes. It was apparent she had over 90% burns to her body. She had a high BMI, so she true to say that she had quite a lot of weight to her. And the reason I add that context is because her airway was very difficult. She had a big neck and difficult mouth to try and articulate some of the landmarks to intubate. So we pulled this patient out of the ambulance to get 360 access, which was right to do. The context then was difficult. There was good light, but there was an onlooking 20 plus colleagues, fire brigade colleagues, ambulance colleagues, church congregation colleagues, which we tried to kind of partition.
Yeah, but manage those.
Yeah, which is difficult because that's applied pressure in a different way. So just
I was going to say there's multiple applied pressures. There's the social pressure, as in the public. We've got to save your friend, your peer, somebody you love, respect. And then you've got the professional pressure that's around there, where you've got the other emergency services looking on going, hey, you're the expert, guys. Sort this out.
Indeed. And then the part of the issue is exactly that, Gareth. And then doing a procedure which is a halo procedure, so a high acuity, low occurrence, and one which I had only ever done in practice in simulation, not actually on a patient. And there's team responsibility and there's individual responsibility, and part of that team responsibility was, verbalizing the plan. I really don't think we optimized for that, and I don't think we brought, and myself included, brought the wider team along onto what Plan B or Plan C was, and how that might happen. And there's definite reflection and learning in that. So it became a can't intubate, can't ventilate situation where we couldn't. There was no articulated landmarks in the airway that we could use to find the trachea to put the tube down. So it became quite apparent she wasn't ventilating, wasn't oxygenating very well. It became apparent that we needed to do, because of the severity of the burns, a surgical airway. Did a longitudinal cut to try and get to the landmarks.
Is that basically through here then?
Absolutely, yeah, through the neck. Bled profusely, all of which time, she was partially anaesthetized with an LMA, so what we call an iGel, which is a different type of airway, which wasn't robust enough to see her through the final procedure. Very challenging.
You say that is actually is it a gaseous anaesthetic then to try and keep her down? So you've got if she's not ventilating, then actually how do you get that anaesthetic into her? Because she's not going to.
Indeed. So it was a pharmacological anaesthetic. So it was one given in her veins.
Okay, right.
And so but we needed a definitive airway, and it was apparent that this what we call an iGel laryngeal mask airway was not sufficient. So she needed something a bit more robust to secure her airway. It's a very challenging patient. First time we'd done this halo procedure, I had laid the surgical airway kit out on her chest. She was anaesthetized at this point. She had a massive emesis, and when I say emesis, vomiting episode. So the iGel came out. She was put into a semi-recumbent sort of prone position. All my airway kit went everywhere, so almost scattered everywhere, which was an absolute nightmare. Managed to get a semblance of control again. We managed to complete the surgical airway. It was extremely challenging on this patient because of her size, because of her physiology, and also because it was very difficult to articulate the landmarks. There was extreme amounts of blood, and it was really, really challenging. Managed to get the airway in. The cuff tore, so we had to replace the endotracheal tube to get a different endotracheal tube into her neck. We managed to take her to the local hospital and then transfer her up to the Burns hospital. When we got outside on the motorway, we could see the Burns hospital. The ambulance ran out of fuel. So we had to transfer the patient from one ambulance to another because we were stuck on the and we were running out of oxygen. So there was multiple stressors within this case. It was really prudent to A, take personal ownership, B, take team ownership as a team, because there was, there was individual and team things we could have optimized for, and just reflect and see how we can improve. But it certainly was individual task and environmental. We had plus 30, maybe even 40 people watching. We hadn't really brought the team. We hadn't done a robust team brief. The patient
I'm
was
interested
extremely challenging.
This we talked about individual ownership and the potential for sitting there and playing counterfactuals. Because you sit there and go, I should have done this, or we had the opportunity, we should have done something at that time. And you just said right at the start, this is the first time you've done it before. And it's that sit there, and when I play the sort of serious games in the training that I do for non-technical skills, well, I put them in a novel space-based simulator. They've never used it before, and I'm running a train the train at the moment. Got a couple of experienced facilitators, operational aircrew and engineers, and they know this, and they still struggled. And one of these guys, he's been used to operating in a war zone, in an aircraft, doing lots of stuff, and his cognitive load off the scale. He said, my head was full. I had no ability to see what's going on. And this is a fairly simple task. And I said, look, you've never done this before. So it's all very well saying, we do it in the sim. But the sim, in my perspective, is often about the technical skill acquisition on I'm going to say your dummies are probably fairly standard BMI dummies as well. You haven't got, stuff that makes it hard in the real world. And often people beat themselves up, especially those in very professional ownership spaces like paramedics, those who are very competent. And they sit there and go, I should have done so-and-so. So can you expand what you mean by ownership in the moment, or how I perceive you mean ownership in the moment and the realities, and also ownership afterwards?
Yeah, indeed. So we all run through, and to your point, Gareth, putting people into unfamiliar environments. Subconsciously, we run these scripts in our lives, whereby when we've been in a situation, we've got terms of reference, albeit n plus equals 1, once or twice or 3 times. But you've got some semblance of baseline, right? I've been here before. I've done this. I know what is forthcoming. I know what I'm doing now. And certainly within paramedicine and critical care, we have these illness scripts where we've seen a pathology in front of our face. We've done something before. It's worked in some which way. And so the process of heuristics takes place. And the heuristics are these mental shortcuts which allow certain outcomes which you rely on. And that's nothing more than a metacognitive process, a neural link which allows you to reach into the past and find some terms of reference. Now, when this is your first attempt, and to your point, Gareth, it's very different to the attempt you experienced in simulation. The patient actually physically bleeding. You've got you've got plus 30 people looking at you, some medical, some non-medical. You've got extremely difficult patient, which wasn't the case in practice. But they didn't have a high BMI, didn't have a big neck, didn't have burnt skin, 90% burnt skin, didn't have screaming relatives in the background. It's multifactorial, it's multimodal, it's multisensory. So you've got your senses are going crazy. You've got environmental factors impinging on you, noise factors, and it's everything that the simulation was not.
Yes.
Everything that the simulation was not. And therefore, whilst the simulation is useful, you can only garner a certain amount of utility from that simulation, because there is no there's no historic and or motoric script you can rely on that gives you any terms of reference to where you are now, with an extremely challenging patient, extremely challenging team dynamics, intra-team and inter-team. So between me and the doctor and us and the wider team, and all these aspects need to be sat down, looked at, focused on, reflected on, and see how could I have optimized in those situations. Trying to practice safe medicine is often about doing the basics well. Did we do the basics well? How can we then build on that? But what were some of these impinging factors that I can mitigate in the future? How can I brief?
This is very much about future projection as opposed to past beat yourself up.
Absolutely.
Because I should have done that. So that's a really powerful piece. And I think it's something that it's hard to get across to people the past is the past. It's gone. And it's also, and why, this podcast is about as well, is it's really easy to sit there and judge events through a very simple linear lens. And you sit there and go, well, you've done your training. You're a HEMS paramedic, so you must be pretty shit hot to get to what you do. You're working with a doctor who's there as well. You wouldn't be in that space if you weren't good at what you're doing. So why is it you struggle with this? You've done training. And you sit there and go, well, actually, there's a limit to what's going on. And to me, it's this need to share those stories. So then moving a little bit on is, how does the HEMS space and the paramedic space build those mental models from those, I'm going to say halo, or it's, sort of low event situations.
Yeah.
So you could build those mental models, because the likelihood of you encountering another casualty in exactly the same situation is pretty slim.
Yeah.
So how do you pull the key learning points out of that you can then abstract and build into your library of experiences?
Yeah, so fundamentally, it's a great question, Gareth. Fundamentally, there's two different aspects to this. One is HALO, so high acuity, low occurrence, and one is HAHO, it's high frequency, high occurrence. So it's what you're starting to look at is, what do we do daily, frequently, that we can still learn from and get better at? What do we do infrequently, which is high acuity, that we can get better at? So there's two different aspects here. Now, it's prudent to look at both, because I actually think you can still garner improvements from things we do on a daily basis. But it's reflection. Fundamentally, it's reflection. It's reflection as a team. It's debrief. It's hot and cold debrief. It's looking at analogues of training that mimic and that align far more with some of these human factors you'll see in practice, so that you're not in a foreign land when you're practicing it for the first time. You've started to understand there is these environmental factors that you need to mitigate, because you've seen that in training. There is this, either, you've started to mitigate the fact that the patient might vomit, so putting the airway kit onto the patient on the trolley bed is not the best idea. But
But I can immediately see the advantage of that is, if the patient's on the trolley, the patient is at sort of waist level, and so now you've got the airway kit there. So do the trolleys have little fold-out shelves that you can pull out from underneath the base that allow you to put the airway kit there?
Yeah, which is great, actually. And they do not. And that would be a great human factors sort of system design for trolleys. Yeah, they absolutely would. But the big thing here, Gareth, and something I really want to hit home is, and you mentioned it earlier, and this is profound, it is your relationship with failure, because you cannot go into the past. You can't. And I see, and you do too, people who get tied up in knots about the past. The best F1 drivers can leave the last corner behind them. The best F1 drivers can leave the last corner behind them. And what that means is your past performance doesn't affect your future performance. You don't let the predictions of past performance reach into the future. And me and you have both seen people that cannot move through and move past their failures to perform optimally in the present tense. And if you cannot do that, then you will never really operate A, to your full potential, or B, as an effective person and or clinician, because people, and this is just the reality, sometimes whatever you do for people, they sometimes will die regardless of what you do. The situation, you can mitigate as much as you want, and you can't necessarily optimize. And so in certain terms, you have to fundamentally come to peace with the past, reflect on it and learn, and move through that. And if your relationship with failure is not in a good place, then you will always be the second best version of yourself. And you can test for this. You can absolutely test for this.
That's a really powerful piece, just understanding. And failure doesn't have to be that failed outcome. And again, there's a sort of real sexiness and attractiveness of good outcomes. Now, you may have been lucky to how you got to where you are, and you had a failed process, but you had a good outcome. And you go, hey, that's cool. But you don't then reflect on how you got to where you are. And, one of the things that I often talk about is this, are you lucky or good? And there's nothing wrong with being lucky. Just don't call it skill. And it's that bit of sitting there going, right, how do we understand the situation developing the way we do? And it's through those debriefs, those storytellings, and sharing of that. But that only works if you've got a culture and an environment that allows that storytelling to happen, where you go, you know what, I had a complete train wreck of a patient here or a situation because of X, Y, and Z. And it's that bit of shutting down the conversations of, well, you should have done X, Y, and Z. The whole counterfactual should have, could have, would have, Captain Hindsight comes to play. Whereas actually, okay, so how did it make sense for you to do that? What were the visual cues and clues? You talked about, the words used, the landmarks in terms of trying to intubate that patient, which means, there will be things that I'm just interpreting this, that there's a camera and you're looking for bits where the body is structured a certain way, the physiology's there, and you sit and go, right, that's there, that's how I'm getting this airway in. Can't see those. And that could be because of the patient's size, shape. It could be because of the burns, the injuries. Okay. You then go to the person who was successful and you say, what did you use? What did you see? What was different from what's normally there that then can help me guide those bits?
Yeah, no, listen, that's profound. One, I'm just pick up on that, Gareth, because we are fundamentally unifocal. We're not multifocal. So what that means is we have an intentional blindness. And so therefore, what we can only do, especially in a time of catecholamine or adrenergic response, so our adrenaline is pumping, things are going wrong, your any semblance of peripheral vision goes, your hearing, you start to have hearing loss, and you become truly, and it's an evolutionary concept whereby you actually need to focus on what's just about to kill you. And so you can see why we are unifocal. But to your point, we need to ask, what am I missing, and how did this look from your perspective? Because from my perspective, I was circling the drain. My physiology, this was difficult. There was multiple points which was difficult. I lost most of my sensory inputs, my hearing, my peripheral vision, my sense of time. Therefore, I need when we're not in this fight or flight response. Right? How did that look to you? What were some of my gaps? I can articulate some of them. You're going to need to help me because I had the amygdala hijack. I was hijacked by all, and understandably, because we just need to get through this one thing. But actually, I need you, and this is part of my revelation, Gareth, is you need the team. You absolutely need the team. So one of the things you said, which is true, you need the team to give you permission to fail. And you also need the team to give you feedback, because there's going to be lots of things that you missed along the way that you can correct through getting their feedback. So you always need the team on board. You also need to practice forgiveness, because when you're in a mentorship role and other people are fail around you, you need to facilitate that and learn from that and give them permission to fail, because ultimately what you want to do is grow this relationship with failure, where they learn it, they understand failure, they don't embody it. It's not the sum total of who they are. They move through failure, they recognize it for what it is, and change as a result. And as a mentor, you need to facilitate that change. You need to help them adapt and adopt a healthy relationship with failure.
And it's an interesting bit there, even the language we've got, failure and learning. And we sit there and go, that failed, not you failed. Where's the emphasis? Or we didn't have the outcome we were hoping for or we expected. And why is that the case? I was just trying to find a paper that I'd just seen probably in the last week. And the reason why it comes up is that team piece. And I think I tagged you in on LinkedIn, and it was talking about the difference between doctor paramedic teams and paramedic teams, and the diversity of thought and the piece in there. And I can't, did I tag you in on that? Good. So I haven't read it other than just the sort of the overview. What have you looked at it, and what are your thoughts on it?
Yeah, so I interviewed Mike Christian, the author of the paper, last night, actually, for the podcast I run.
Brilliant.
Yeah. So there's lots to say on that, and partly it's due to ceilings of care. So the way that interprofessional teams train and indeed practice. Part of it is, and this is a really interesting piece, and this is one of the really interesting missing pieces of the puzzle across the healthcare spectrum. When interprofessional teams and interdisciplinary teams train together, you vicariously and informally learn from someone else's profession. So that actually the utility to working in an interprofessional team across the healthcare spectrum, it might be a diabetes clinic with a rehabilitation clinic, it might be oncology with surgical, it might be surgical with the emergency department, it might be the emergency department with pre-hospital care, so with paramedics. It occurs across the spectrum. But when I learn from your specialist domain, how you move, how you act, how you question, how you reflect, I become better. And it's a lot of this, up to 90% is informal learning from interdisciplinary teams. Now, this is powerful because this is not just within healthcare. This can occur throughout life. So I can learn from you as an advanced diver. I can learn from how you reflect. I can learn from how the questions you ask. I can also learn from your relationship with failure, like how you become far more objective than subjective. I can tell you in a second, and I can see in a second if you're lost in your subjective relationship with failure, because there's this self-musing, this self-deprecation, and there's this almost this polarization. But if you can be far more objective and actually pull other people along on that journey, proof of the pudding. The F1 drivers that can put the last corner behind them are often the ones which succeed and are often the best. They can draw a line under their failures. They learn from their failures. So this interdisciplinary team working, it doesn't have to be siloed to specific skills. The life learner can learn from multiple domains of practice and bring it back to their own domain.
That's brilliant. It's really good, and it's my experiences in the simulations I run, and one of my human diver instructors is the diving safety officer at Georgia Aquarium in the States. And when we were running through his instructor assessment last March, April time, I had a previous guest, and you might know him, Jason Coyle, who's an incident commander, incident management commander in the States, fire wildlife firefighter. And he attended one of the classes. We had 3 classes running. We had a software guy who team agile scrum stuff. We had Jason, and then there was the third team. We had another person who was outside of the team. And Jonathan said, actually, the value of having a different perspective was incredibly powerful. And both ways, because, all of the outsiders got something from the inside team, and the inside team got insights about how others operate. And to me, that diversity, and I don't upset people because it's the need to, it's not surface diversity. That's important. And sometimes we get cognitive diversity based on surface diversity. But in uncertain, that whole VUCA space, if you're going to be operating in a dynamic situation, having different perspectives is critical. Because it's just like I just said now, have you thought about a fold-out table from the paramedics table? a fold-out shelf. It's like, because to me, that makes sense. If you haven't got anywhere to put the ventilation kit, well, you're going to use the patient's body because you've got nothing else. You don't want to put it anywhere else unless you get somebody, a bystander, can you just hold this for me, please? And then now they're sitting there right in it. So actually, how, the whole human factors premise, making it easier to do the right thing and harder to do the wrong thing.
Yeah.
So it's lovely talking to this, and the where you a number of years ago invited me up to this sort of World Extreme Medicine Forum up in Edinburgh. And it's like, oh, cool, got an opportunity, and I learned from the community there as well. So one of the things that I always say to my instructors and facilitators in developing, you learn as much from the class as they learn from you. And if you go in there with this premise that says, and you start off with, you're the experts, I'm going to learn from you, I don't know this stuff, then you will have that learning approach. If you go into the class to say, I'm going to teach you how to do this, and I'm going to teach you how to pass the class, there's no incentive, extrinsic or intrinsic motivation for me to learn about what's going on. So it is absolutely being in a lifelong learning position.
Yeah, so you're right, actually, Gareth, and there's multiple drivers here. So you're right, I very much have learned from the expedition community, which intersects with the humanitarian community and also intersects with the tactical community, tactical medicine, and also the diving community, and also various other sort of expeditionary facets. But you mentioned something there which I learned from this and from the community about this VUCA world. So let's just unpack that. So yeah, volatility, uncertainty, complexity, and ambiguity. Now, volatility is around the rate of change, really, and that change is occurring far quicker than you can predict. So there's a dynamic element to the environment. Now,
and in different directions as well.
And in different directions, absolutely. And directions you may not have planned for or have any mitigation strategies for. Therefore, what systems are serving you or will serve you to maintain a semblance of continuity and safety? So that's prudent to understand that. And actually, the community, the World Extreme Medicine community, live in certain terms in this VUCA world. But then we've got you've got uncertainty, and uncertainty is being unclear about the present. So there's you're unclear about what's happening in the present tense because you are unifocal. You do not have a grasp on the entire environment, nor could you. But actually, what systems and processes are you implementing right now to create a certain semblance of certainty as to where you are, so that actually we acknowledge
the uncertainty.
Absolutely. There's uncertainty in the environment. What can I be certain of right now, and what will serve me going forward to get me a semblance of certainty in this uncertain environment? And then we've got and then we've got complexity. Complexity really is that there's multiple key decision factors. Now this is important because in our world and in your world there are decisions within decisions, and it's not a decision in isolation. Often the decision you take is in a group. It is actually in a subset of larger decisions. And actually, how can we make small, sensible decisions in this VUCA environment, whereby we are starting to decrease the complexity, so that actually there's a certain level of simplicity in some of these fundamental small decisions, which decreases our complexity and potentially our decision making going forwards and the decision making of the team. Because fundamentally, most environments are complex. It's just whether you choose to acknowledge it and are aware of it. Yeah, absolutely. Yeah, absolutely. Yeah. And then lastly, ambiguity. And ambiguity is key here. So lack of clarity about the event or meaning of an event. And this is really around just being explicit in your communication, and getting read receipts, and then sitting back, not being overbearing, not being dominant, but being explicit. So I get a read receipt from you. I actually loop for understanding. So you may call me, call back the task I've asked you to do, but then I loop back maybe in a minute, 2 minutes, just to say, everything on track?
Did you get the result you were expecting?
Exactly.
Yeah.
Did it work for you? Did everything that I said worked? Is there anything else you're missing right now that I can help you with? So you're looping, and what you're doing in this, you're decreasing this ambiguity and this and actually, especially even in uncomplex environments, increasing the valence of clarity in your language, in the cadence of your language, even in the tasks, and then you're coming back in to make sure that they are comfortable in that and they're getting the appropriate feedback. And actually, what I realize is simple things are not simple. So even saying VUCA, and actually, there's a lot of learning in simple things because there's better ways we can do simple things.
Absolutely. And this brings me back to my sort of key business space of developing crew resource management, non-technical skills in teams. And they have massive value in high pressure VUCA situations where you've got lots of uncertainty, ambiguity, because what we're trying to do is create that shared mental model within the team to say what's happening now and what is most likely to happen next, and what are the plans B and C. And when you're in that team space, my mental model and yours have to be as aligned as possible. And the paradox here, or the dichotomy, the conflict is you don't want a mental model or you overlap when you have groupthink. Conversely, we don't want to have separate thoughts. And I have a little animation of Mika Ensley's team situation awareness model, which is basically circles growing and shrinking and overlapping, because these mental models are dynamic. They're not linear. And that's one of the limitations of paper-based or flats, of that sort of learning, is it's two-dimensional and it's fixed. In the real world, those mental models open and close and overlap and disengage based on what's going on because of your models and the sharing and the interactions that need to happen. So,
no, definitely. And just to your point there, Gareth, what we have to appreciate is our anatomy. So your dorsolateral prefrontal cortex and your short-term memory is absolutely finite. And so 7 pieces of information plus or minus 2. So actually, if you overload the short-term memory with too much information, or you don't chunk information down, and this is classic in handover of information, handover of a patient, or indeed of any, and you look at military briefings, 124 slides.
Absolutely.
Or any kind of briefing which is complex, and you've got plus 60 slides. You have to appreciate and understand the anatomy and the physiology you are dealing with. We all have poor short-term retention of information. Therefore, I have to chunk information, I have to keep it simple, and then I have to come back and loop, come back and loop for understanding. And someone who doesn't understand that, I now have come to a place, Gareth, where I know my best presentations are the ones where either there's no bullet points or there's 1 or 2 bullet points. And I'll just speak from an image, because I can bring the story out, the lessons learned from the image. I know that people are unifocal on me. They're not trying to read a slide and look and listen to me at the same time. But you've got to appreciate the baseline of anatomy and physiology, that people cannot retain complex information.
And the important point here is you have the competence and the experience to join those dots in a cogent way. And so if you look at how does it make sense, why do people put bullet points up there? Is because they're not given enough time to consolidate that information. And we then have that tendency when we're incompetent just to read the slide and we read the bullet points. And I could run a whole day presentation. I'll put the slides up there, but I don't look at them. And it's that bit, but that takes time and effort, and organizations don't invest in that because all they see is a deliverable of 100 and something odd slides. You go, there we go, learn this. So it's really cool to have such a powerful human factors conversation about dealing with uncertainty and complexity and ambiguity in these situations, and hoping that people can then abstract that into their own space. And that in itself can be a challenge, because if you don't understand the theory, I often make reference to a slide from John Flack, which talks about this piece where you go from the concrete in the bottom right-hand side of the slide to the theory up in the top left, which allows you to abstract up and say, what does this actually mean? And then you can come back down into another space. Now, if you don't understand the theory in the top left, you can't jump across domains because you don't see the hooks and the connections that are there.
And as to why they're in the meeting we're in now in various domains. But the secret sauce is signage. I'm going to relieve my cognitive burden of trying to remember 15 names. I'll get them to put name badges on. But fundamentally actively listening, because what I want to do is bring their context. So I want to actively listen to their background, because what I want to do is I want to bring the information I'm just about to present into a relevant context for their background. So I will pay attention to your background. This is Gareth Locke. He's a diver. He is, he's X, Y, and Z. I've done this, that. Right. I'm gonna make a little mental anchor, a little mental note. I might put an anchor. You're right.
Yeah.
Anchor, diver. Right. I'm gonna bring whatever I say into context for you and 14 other people. Because what I've done is I've listened to your background, yes. and then you've got some terms of reference to hang your hat on and hang your information on that will mean something to you. You continue to contextualize, and it's that personal touch which I think we lose. And I'm using your name now again, because names are such a personal thing that we blurt out this name at the start of a conversation, but and no one remembers them. But actually, they're the most personal thing about you. So, Gareth, tell me about tell me about your time as a diver in this situation, because I think this slide probably is relevant to you. An open question allows you to speak into it, personalizes the context. So it's the secret sauce is in the active listening, and it might just be one key feature utilized with your name. And what you're starting to do is to your point, Gareth, you're starting to let the room instruct you.
Yes.
You're not instructing the room. You are an active participant and learner in the room. Now and you're not the teacher. You're the facilitator.
Yes.
And there's a powerful pivot and shift.
Yes.
Because all I'm saying now is I am signing up to listening in this room as much as you are and learning as much as you do, because you've all got fundamental stories that I can learn from. I've got a story too. We'll all share. But I'm going to facilitate this. I'm not going to be the high and mighty teacher in this situation.
Excellent. That's really cool. We could talk for ages and ages, and we both got things to do, and our listeners have as well. So the final piece of the podcast is a book or a paper, a presentation, multiple versions that you would recommend others would watch or read, listen, whatever. And I'll put those in the show notes. So what have you got for us then, Eoin?
Yeah. So I've got a couple of things, really. I've got The Design of Everyday Things by Don Norman. Yeah. And that's a fantastic book, really. Don used to be chief designer at Apple. He's worked in multiple contexts. He just brings you back. So a lot of what I've said here really echoes some of the books I've read recently. Don't assume that simple things are simple. Look at the simple things, question as to why they're simple and why they work so effectively. So check that out. Don Norman, Design of Everyday Things. The Practice by Seth Godin, again, comes back to the fundamentals of storytelling, the fundamentals of content creation, of who you are as a person and why it's important to be the way you are. And then something I recommend, and above all, and if no one ever remembers anything else from this podcast, I want them to do this one thing, which is Make Brilliant Work by Rod Judkins. Now this book has changed my it's changed my life. Make Brilliant Work by Rod Judkins. Judkins, Judkins. Yeah.
Eoin, thank you very much for your time this morning. It's been a great thing, and I'm really looking forward to more conversations about what we can do in terms of digital learning and things. So have a great day, have a great weekend, and we'll catch up with you soon.